Good evening, everyone, and welcome to the second National Pleural MDT, which we are doing today. We have three case presentations today, and we have a panel of four esteemed panelists with us. Today, the panelists include Dr. Mohammad Munawar, whom all of us know very well. He is a professor and consultant chest physician at Lancaster Teaching Hospital, Preston, UK. Then we have the second esteemed panelist, Dr. Manu Chopra, who is professor and head department of respiratory medicine at Arms Institute of Cardiothoracic Sciences, AFMC, Pune. Then we have Dr. Vrishali Khadke. She is a consultant pulmonologist from Pune Hospital. And the last but not the least, our esteemed surgeon, Dr. Kamran Ali, is a principal consultant thoracic surgery he is the lead surgeon lung transplant at Max Super Speciality Hospital, Saket, New Delhi. So welcome to all of you. And now we start with our first case presentation, which will be done by Dr. Srinivas Gopinath. Dr. Srinivas Gopinath is an associate professor of thoracic surgery at St. John's National Academy of Health Sciences, Bangalore. He'll be presenting a first case today. After each case, we'll be having a panel discussion. Everything will be live. So, Dr. Srinivas, please start.
Yes, sir. So I'll share my screen and get started. Is my screen visible to everyone?
Yes, please.
Okay. Good evening. At the outset, I would like to thank all the organizers for letting me be a part of this wonderful forum and allowing me to present my case in this second National Pleural MDT. Greetings from Bengaluru. I'm from St. John's National Academy of Health Sciences. Just to start off right away with the case, we had a 26-year-old lady who was married, non-smoker. There was no significant exposure to any biomass fuel. She presented with complaints of a painful mass over the sternum, more on the right side. And past history was significant for being treated for severe pelvic endometriosis. And she was on medical management with progesterone tablets for the same. On examination, there was a 2-centimeter mass over the upper part of the sternum. It was quite painful and tender. And on the respiratory exam, there was mildly reduced air entry on the right side. So considering this, to evaluate the mass, we went ahead and did a CT scan. And we found this mass to be over on the right lateral border of the sternum, measuring around 2 into 3 centimeters. It shows some indistinct borders with the sternal bone, and as well as probably very close to the internal mammary artery on the right side, which was not clearly seen. So on further imaging, this was the video of the CT scan. This will show you the mass more clearly, the contrast enhanced scan. If you can see here, yeah, that's the mass. No other significant mediastinal findings, no lymph nodes. And surprisingly, when we switched to the lung window, we found that she had a pneumothorax. Other than that, there were no obvious nodules anywhere, nothing really suggestive of any other pathology. Considering the past history of endometriosis and this particular painful mass in the sternum, we went ahead and we put in a chest tube first for the pneumothorax. The lung fully re-expanded. And after that, we did a FNAC of the sternal lesion, which showed endometrial cells. So then we went ahead and did a diagnostic thoracoscopy, which showed multiple diaphragmatic deposits, no pleural or no parenchymal lesions to explain the pneumothorax. Took a biopsy of it, and the result was endometriosis. So at this point, there was various questions and various options for us. I'll stop here and ask ask the panel to continue and to see what is the appropriate next step in this particular patient.
Thank you, Dr. Srinivas. This seems to be a very interesting case. Now we start our panel discussion. As we are two moderators for today's session, Dr. Richa Gupta, she is the professor in the Department of Respiratory Medicine at CMC Vellore. Everyone knows her very well. And myself, Dr. Sushil Jain from Ramakrishna Care Hospital, Raipur. So today we start with the panel discussion of this case. My first question is to Dr. Munawar, sir. Sir, what are the most common presenting symptoms of pleural endometriosis, or when should we suspect pleural endometriosis? We want to know from your experience how you handle these cases and how you diagnose these cases. Dr. Munawar, sir, please.
Thank you, Dr. Sushil and Dr. Srinivas Gopinath. Fascinating case. I must admit, I have not come across many cases here with pleural endometriosis. Nevertheless, the classical symptom, which I presume this lady had, is catamenial presentation of either pain, hemoptysis, or pneumothorax, catamenial pneumothorax, that should make you think of pleural endometriosis. And the workup should be accordingly. I mean, the even more fascinating bit here is the presence of that mass higher up, because you can expect something on the diaphragm in pleural endometriosis, but the mass higher up, which are also near the sternum, giving us a diagnosis of a pleural endometriosis and FNAC is quite incredible. I haven't come across before. I don't think I have anything else to add, except for wondering about the role of thoracoscopy here. I don't know what everybody thinks. I think, was it necessary? Was it essential? It's a debatable issue.
Any opinion from the panelists?
Yeah,
on whether we should have gone for a thoracoscopy or we should have not done it?
So, can I just say something?
Yeah, please.
In case we didn't have that, the subcutaneous kind of a mass which was extending behind the sternum or beneath the sternum, I think in that case, we to kind of reinforce the diagnosis, it could have been. But with this small pneumothorax one, I wouldn't have been put in an ICD. And because the subcutaneous thing showed you the endometriosis, then with a person who's a known case of endometriosis and possibly a catamenial kind of a history, I would have deferred the thoracoscopy in this case.
Any other opinion?
Sir, what I feel, why should we defer thoracoscopy? We should have gone ahead with thoracoscopy like we have gone here. We have found endometrial deposits in a mass on the right side of sternum. There's a pneumothorax. Agreed, it could be a catamenial pneumothorax, but we still need to find that is the pleura involved. Now, in this case, visceral pleura was involved. The second step which we have in our hand is that to go ahead with a pleurodisc. Thoracoscopy is a good option to do for first see the defects and then do a pleurodisc. Progesterones, GnRH analogs are I think so, a later part of therapy. But as a physician, respiratory physician, I think so the management protocol which you had followed was good.
No, what's the opinion? So, please.
Sorry, Sushil. The reason I was asking the question, not to say that we should not have done thoracoscopy, I was actually encouraging discussion, because in these sort of scenarios, there are pros and cons of thoracoscopy. One important thing is that this patient was already on progesterones, had a diagnosis of thoracic endometriosis, and despite systemic hormonal therapy, despite that, the mass occurred and there was a pneumothorax. So a more definitive diagnostic procedure is a reasonable step here. One thing I wanted to perhaps bring in just to ask Kamran is in these sort of scenarios where there's solitary abnormality only in the hemidiaphragm, I presume you will have more experience than us in taking biopsies from the diaphragm. Is it safe in a patient with endometriosis? Are we more likely to cause damage to the diaphragm and suspected endometriosis?
Right, sir. So, first of all, Srinivas, very interesting case. I've never seen a
sternal mass in a case of catamenial pneumothorax and endometriosis. So we do aggressively do thoracoscopies for a suspected catamenial pneumothorax, especially in a patient who has had pelvic endometriosis, because I believe in whatever little knowledge I have is that the chances of decreasing the recurrence are higher when you deal with the endometrial deposits in the pleural lining as well as on the diaphragm during VATS. So as a principle, when we have a patient who has catamenial pneumothorax and when we go inside with a scope, our goal is to, if we have any deposits on the pleura or on the diaphragm, we excise those deposits. If we have fenestrations on the diaphragm, we would either suture the fenestration, or if it's a large fenestration, we would pick up the diaphragm and staple that area. And there's also, in fact, there's a paper from 2025 where there's a lot of evidence which says that if you have a large surface of involvement with the endometriosis, a lot of deposits, then actually there's this role of putting in prosthesis. So a lot of people are resecting diaphragmatic lesion. In fact, this was a European study across 5 centers, probably also some center in UK. So they would resect all the diaphragmatic deposits. And if you feel that you have weakened the diaphragm and there's a risk of herniation or whatever, then you reinforce the diaphragm with a mesh. And they also saw that the mesh, if you're using a prosthetic mesh, there was very minimal recurrence. And if you used the biological mesh, there was no recurrence at all in those patients. It's a probably a 15-year experience from those 5 centers. So we also do aggressively resect these lesions. But my question here would be to Dr. Srinivas. When you put in a scope, what was the status of the internal mammary artery on the right side? Because in this CT, the internal mammary artery looks invaded, and I'm not sure if we can, deal with this lesion by VATS. So I would.
Yeah, that was the problem. It was invaded. It was going through the lesion.
Munawar sir, I think you probably have a comment.
No, just going to ask again. This was reasonably appropriate management. I'm not judging the management, but the question is, when the CT looked like the pleura was completely normal, based on what you have said, Kamran, should we, in these scenarios, have an MDT discussion and choose to go down the surgical route for isolated diaphragmatic lesions? From what you have described just now, from what you have said, is a question that arises in my mind.
What do you say, Dr. Kamran?
Yes, I mean, of course, sir. I mean, an MDT is always the best way to go forward with the benign or malignant lesions, especially which are not very common. Since this was a classic case of catamenial pneumothorax with a background history of pelvic endometriosis already under treatment, we usually prefer, because pulmonologists at our centers do not. I mean, they would of course go in. They can do pleurodesis, but the principle we follow at our center is to resect the endometrial deposits. So that's why these cases come to the surgeon here in our center at least.
Um, uh, Dr. Kamran, I just wanted to ask you, usually the pleural deposits is there, then it would be shown up on the imaging?
Ma'am, to
Not
be
necessarily.
honest,
Not necessarily.
if the pleural deposit is very huge and it's
Yeah.
it's elevated, it may be. I mean, we can pick it up on a CT scan. But if usually these are flat kind of lesions, I haven't seen any big deposits. I mean, when this kind of a lesion that you were seeing on the sternum, if it's there, of course, it will be picked up on a CT.
Right.
Otherwise, usually we pick it up on a thoracoscopy.
So when we are, no, so my question is there any study or is there any comparison head to head where these flat lesions, we know that otherwise also even malignancy or TB or lots of things, you may not see the lesions actually because they are flat and you see it only on thoracoscopy, whether medical or vets. Is there any study or research where they say that doing these patients which are flat, which is not interfering with any kind of functioning, can we just pleurodese them directly, or you have to resect and then go ahead?
I think, ma'am, to the best of my knowledge, there's no study that compares this. And I don't think there is any consensus or international guideline on the management of
Yeah.
these cases. It's, I
Right.
think, institutional based protocols, most of the places. That's what I
I
And
think a lot of people do resection followed by diaphragmatic repair and pleurodesis. That's the usual thing I have also seen whenever
Yes, sir. So
get involved.
I forgot to add that yes, we also end up doing a pleurodesis. Whatever we may do, just resection or even putting in a mesh. I haven't personally put in a mesh because we've not come across very extensive lesions. But I mean, I'm assuming if we even put in a mesh, we would definitely do a pleurodesis for sure.
Okay.
I think so, sir. In 2023, BTS guidelines do mention pleural disease in these cases. Uh, so there are guidelines for management of catamenial pneumothorax, and that's on the first instance only. When you see them, when you are very sure that this is going to be endometriosis, you do a biopsy and subsequently do pleural disease in these patients. So whatever I remember, the latest guidelines do mention pleural disease. But I have only seen one case till now, and I don't know what a chance of recurrence of pneumothorax in these patients after pleural disease. Esteemed panel, if anybody has any experience on that, sir. And if you do a pleural disease, do we have recurrence from that side, sir?
If I may comment,
Yeah,
Sushil and
please, sir.
Richa, just a
Yeah.
couple of things. One is the point that Richa quite rightly raised about imaging guidance. As a general rule, not specific in endometriosis, there's a very nice paper from which I was co-author of, from Rob Halifax from Oxford and Thorax, looking how the CT imaging underestimated the abnormalities prior to thoracoscopy. We also did a local study which was presented at the BTS, similarly showing that it's underestimated. So that was the reason I was asking the question. The people involved in this care quite rightly did a thoracoscopy, I would say, because there's already a pneumothorax, it's appropriate. But we cannot go just by the CT appearances. The second point about pleurodesis, in these patients, there are pros and cons, there's not much data, and one has to remember that this is a systemic illness. And sometimes the MDT approach with the gynecologist to see how we are going to manage this patient, because some of them end up requiring very aggressive endometriosis, end up requiring even hysterectomy and oophorectomy in these patients. So that's the reason I initially talked about the MDT approach, not just with the surgeon, but also the gynecologist in this patient.
Usually it's a combination therapy, hormonal with surgery in case of patient who having recurrent symptoms or recurrent pneumothorax. And if endometriosis is not been taken care only by hormonal therapy, then a combination therapy is usually done. Surgery with hormonal therapy. How do you do, sir? What's your take on it, Dr. Munawar?
I think you have to individualize. This is an extraordinary case. And I think in my practice, I would have certainly got the gynecologist involved as well, and the thoracic surgeon, and the radiologist, the chest radiologist, and us. So, and depending upon various factors that need to be considered, you have to, it's horses for courses, you have to decide what's best for this particular patient.
Okay.
this patient was already
Can I-
on progesterone. Please, Vrashali, sorry.
Yeah, so things which are being brought out on this case is the patient has already been on progesterone,
Yep.
only pill, and OCPs or GnRH analogs are the other things which are used, and particularly they go about with GnRH. Now, once we see the pneumothorax, and you see some amount of fluid also in the on that side of the thing. My consensus is that, my thing is that we should be doing a pleurodesis in this case. And of course, when the gynecologist will come in and they will be then escalating the therapy in terms of the hormonal therapy, or like Munawar sir said, maybe a oophorectomy only also in this case, depends on how severe is the case. The other point which I said, that whenever we have a catamenial, of course, we do a thoracoscopy to do the diagnosis as well as you want to do a pleurodesis. My reason why I deferred the thoracoscopy in this case, because there was a lesion which was subcutaneous, which showed endometriosis, and there was a pneumothorax. So we have seen that thoracoscopic this pleurodesis versus a medical pleurodesis, ICD-based pleurodesis works just the same. So I think here, like sir said, we have to individualize the things. I had only one case of catamenial pneumothorax, which was bilateral, and we pleurodised either side, and the patient has never had recurrence. Obviously, she went back to the gynecologist who was treating her, and a diagnosis was based on a pleural biopsy.
So one thing I would like to add here, that it's not, the thoracoscopy is not just for pleurodesis. There are the surgeons
Biopsy.
usually resect the lesions, repair the diaphragmatic defects if at all there, and then they do the pleurosis. So that's the
Yes, sir.
maybe an add-on which may not be visualized on your CT. So I think that may be like
So
much
that
more
is
than.
precisely what Rich asked, and maybe we can ask is that do we always have to resect the lesions, or we do the pleurosis? So do we send it to the vat surgeon because we won't be doing the the resections? And there was a beautiful, I think, picture shown by Dr. Pulle in our IPN network where he had shown the large defects in the diaphragm for a catamenial pneumothorax, if you all remember.
Yeah.
Yes, I remember. So I think it has to be an MDT, and we should discuss all the pros and cons along with the radiologist, gynecologist, and the surgeon, and then a joint decision case to case has to be taken. I think that would be the take here.
I have a
Can I add
question
something?
to ask from the surgeons,
Yes, ma'am.
both the surgeons. What about this sternal mass?
Yeah, that.
Yes.
Ma'am, so can I say a few things before
Yes.
Please,
Dr.
please.
Yeah,
Kamran?
please.
So the first question in my head was diaphragm can be resected, sure, but we can't resect this. I mean, we can resect the external mass as well, but the morbidity will be too high, especially if you're sacrificing internal mammary, cutting out a part of some part of the sternum or anything. And if you're resecting the diaphragm, that's a real major thoracic surgery. So for a 26-year-old girl in a benign lesion doing so much, is it worth it, or just a simple pleurodesis will be sufficient? But the sternal mass is also symptomatic, first thing. And second, wow, what is the cause of the pneumothorax here? The pleura was completely normal. The lung surface was fine. It still baffles me why she should have a pneumothorax. Even, I mean, this is common across catamenial pneumothorax. Most of the lesions are on the diaphragm, and I'm not understanding what is the cause of the pneumothorax. There's no breach in the pleura as such.
Dr. Srinivas, did you do an underwater puncture test for the lung? I'm sure you would have done.
Yeah, I mean, there wasn't like no obvious air leak was there.
No obvious air leak from the lung. Okay.
Okay.
So a breach of the pleura is not necessary
Right.
for pneumothorax sarca, and endometriosis is often is microscopic, and that's the reason that they suggest pleurodesis as a treatment.
Okay.
This condition.
Yeah. What is written is that yes, there could be a small leak and it seals off. You cannot really see most of the leaks.
I think now we move on to the next question. Now, what imaging modalities are most effective in diagnosing thoracic endometriosis, and what are the limitations? This question is to Dr. Manu. Dr. Manu, please. He is not there. Dr. Manu?
Yes, sir. Sorry,
Yeah.
I was
Have
unmuting
you
myself.
heard the question?
I heard the question, sir. I heard the question.
Yeah,
So the
please.
diagnostic modality of choice, as Dr. Kamran has already told, that CT scan, because of these flat lesions, we may not be able to pick up the lesions on CT scan. The endometrial lesions need to be seen. Since they are vascular lesions, I think the PET scan would be able to pick up these lesions much more as compared to a contrast CT or a plain CT. So I think, and second, of course, you have to see these lesions visually by thoracoscopy, maybe VATS or medical thoracoscopy. So we'll be able to pick up these lesions.
So CT scan and thoracoscopy. These are the usual modalities you use.
Yes, sir.
Okay. Dr. Richa, anything you want to add to this?
No,
A PET. Can someone elaborate on the PET? Because as far as I have
Dr.
read,
Manu?
there was not much difference on the PET. Unless you want to rule out something else altogether, you do not have a history which is coming forth of a catamenial pneumothorax. You do not suspect a catamenial pneumothorax in the first place. And if I have a lesion, I have a disease which is possibly just restricted to the thorax, I would err on the side of doing a thoracoscopy before going for a PET. But I mean, could someone just speak about the PET? Because as far as I remember, I do not read that PET has any greater
Dr.
importance than
Munawar, please.
It is
Sir.
not actually, sir. I think so. The diagnosis is clinched on history. The pneumothorax matches the menstrual cycle. That clinches the diagnosis of catamenial pneumothorax. It's more a historical diagnosis, and subsequently, when you intervene, when you do, of course, you do a CT scan, you may not find anything on a CT scan, and then is the next step. You go ahead and see what are the defects, or you find any endometrial deposits on the pleura. So Dr. Vishali is right. PET is not the modality of choice, but in case if you ask me a modality which can pick up, I think so it could be PET only which can pick up. Nothing else should be able to pick up a lesion like this.
Yes, Dr.
Dr.
Kumar.
Kumar.
Sorry. So,
As far as imaging is concerned,
Yes, sir.
CT, it's the CT protocol which is important because it needs to be in the contrast enhanced in the venous phase to be able to see the pleural lining carefully and to be assessed by a proper experienced respiratory or pulmonary radiologist. PET, I'm not sure has much of a role here because of the nature of PET, because of FDG, the dye itself. Would it be picked up by endometrial tiny lesions? It'll be below the cutoff for PET, I think. I've never come across PET being used for this. There is some work with MRI of the pleura in various conditions. Kevin Blythe in Glasgow has done some work, and I wonder whether that may be another proposed modality. But CT in the venous phase is crucial, I think.
if I may add to what Professor Munawar just said, so MRI has a good role in diagnosing these lesions. And there's a lot of evidence, I mean, there are many papers from radiologists where they say if you're suspecting a diaphragmatic pathology based on any of your previous imaging, MRI, especially done during the cycle, helps to pick up these lesions, even small lesions, because MRI is a very good modality for detecting blood. So MRI has a good role for diaphragmatic, but especially for picking diaphragmatic pathology.
Yeah. Yeah. Thank you. I think
I think we come back to the last question, which is unanswered. Can we just locally resect as much lesion which is there in the sternum to prevent the pain, or is there anything else which can be done for the pain which the lady has? Because she didn't come with breathlessness. The primary problem was the pain which is at the sternal mass. So we have done everything around it. Any input on that, Dr. Kamran and Dr. Srinivas?
I would be very hesitant to resect the sternum for pain. I mean, that would probably increase the pain. That is also a serious possibility. Sternal resection, I mean, I'm not sure, but I would be very hesitant to resect the sternum here.
I echo Dr. Gopinath's thoughts that for a benign disease, resecting the sternum is a big thing, and especially this lady is going to lose her internal mammary artery on the right side.
Yes.
And if we, in the future, if she needs a coronary artery bypass, and if you're considering, total arterial vascularization, then this option is gone. Also, I mean, yeah, also if somebody believes in the principle of resecting everything for preventing recurrence, and if we leave this mass behind, I don't know what's going to be the future course of
Yeah, that was the big,
Yeah, any role of any local sclerosing? I mean, just a question, like we do it in most other lesions.
There's no data on that. I don't think anything has been mentioned in the literature much about it. So we tried to search on it, but nearly didn't find much information about this.
Just a query. Since we couldn't do anything, could we just?
So these are rare cases. These are all rare cases which we normally don't see, and there's no much of literature on that. And having a sternal lesion like this is even unusual. So what you did, Dr. Srinivas, can we know from you?
No, I think I was also confused. I wanted to do a pleurodesis, but then I thought if I had to go back in and resect the diaphragm, doing a pleurodesis would be extremely counterproductive at that moment. And we might have ended up doing open surgery to resect the diaphragm. So I didn't do a pleurodesis. We just, I think she was put on GnRH analogs by the gynecologist. And in case she has a recurrence, now that will be the next chapter of this story.
So in case of recurrence, you will consider for a thoracoscopy and surgical resection and pleurodesis. Probably that's the way you'll do.
That's what I'm really hesitant to resect the sternal lesion. If I'm going to leave this and only resect the diaphragm, will it really benefit her?
I'm talking about the thoracoscopy also. I mean, pleurodesis you will do at a later stage. You have not done this time.
No, if she recurs, yes.
Yeah. Okay. I think now we move on to the next case. Any other input, Dr. Munawar, sir?
No, that's fine. Thank you so much.
I just wanted to ask one question. What should be the the line of control, if I would say, medical management versus surgical management for pleural endometriosis? Do we have an answer for that, or it's something blurred, recurrence and then go for surgery like Dr. Gopinath has decided to do? Or on first instant, we should go ahead? Or should we wait for hormonal therapy? And, I just wanted to know. So,
It's extremely important that there's a sternal lesion as well here. So therefore, systemic therapy is crucial. We need to be satisfied that they have done everything possible from a systemic point of view, because that might control the sternal lesion as well and benefit the patient, because the presenting symptom is pain in the sternal lesion. I think that's crucial. And then we'll consider local treatment.
Sure.
Think we now stop here and move on to our next case. Our next case is presented by Dr. Bidisha Devi. She is a senior resident at the Department of Pulmonary Medicine at Guwahati Medical College and Hospital. Dr. Bidisha Devi, please. Next case, please.
Hello, is my screen visible?
Yeah, please. Yeah.
Yes.
Please start.
Hello, everyone. I'm Dr. Bidisha Devi. Good evening to all the esteemed panelists and respected moderators. So this particular case that I'm going to share today, this I actually encountered during my first year of residency. So it was a busy OPD day, and one by one patients were coming up for, they were sent for pleural tapping. And when I did the tapping of this particular case, it was so intriguing and interesting. I immediately called my seniors because I had never seen such a case before. So as I call this case, the black tide, an uncommon complication of a common disease. So, not able to. Okay, so a 45-year-old male, non-smoker, non-alcohol consumer, he presented with breathing difficulty, non-productive cough, and right-sided chest pain for 6 months. On chest X-ray, as you can see, there is bilateral effusion, and right-sided there is massive pleural effusion. So when I did the tapping on thoracosynthesis, it was black in color. But patient had history of therapeutic thoracosynthesis about 5 months back at a peripheral hospital. But back then it wasn't black. It was, according to the patient, it was high colored. So what went wrong in these 5 months? As you can see in the ultrasonic image as well as in the CT also, there is right-sided massive pleural effusion. So we did the pleural fluid analysis, and it came out to be exudative, lymphocyte predominant, and with low ADA. The pleural fluid gram stain and cultural sensitivity came out to be negative. We sent 3 samples for malignant cytology, which were also negative. The pleural fluid for fungal smear and culture was suggestive of hyphae, but the culture report was taking too long. So we drained about 1.5 liter of fluid in order for symptomatic relief. So the patient was then started on azoles based on the fungal smear, and we discharged him on stabilization. So after 3 weeks, the patient returned back to us, and this time his breathlessness and symptoms worsened, and we had to admit the patient again. So we planned the medical thoracoscopy, and the pleura was apparently normal, and on histopathological examination, and non-fibrinous pleuritis was the report. And here also you can see we drained about 3.5 liters of fluid, which was completely black in color. Then no diagnosis we were able to establish so far, and the patient also started deteriorating. So we had to look back again to the beginning. We started probing into his medical history. We asked the patient again his history. And then on probing, we came to know the patient actually had symptoms of occasional pain abdomen, which was non-severe in type for 2 years. And there was also history of consumption of some herbal drink on a frequent basis for his sexual health, which he kept confidential from his family also, and also from us. So immediately we did a CECT abdomen, and it was suggestive of a fairly well-defined loculated peripherally enhancing collection measuring approximately 27 into 20 into 40 mm, which was noted in the lesser sac, and superiorly it was extending into the dome of the left hemidiaphragm, and inferiorly extending to the superior surface of the distal body of pancreas. So this was it. MRCP was done. Then pleural fluid, amylase, lipase were also elevated, and reports were conclusive of pancreatic pseudocyst with pancreaticopleural fistula. So what we did, as the patient presented with recurrent, like he was very much symptomatic, so we did an ICD insertion, and followed by that, we did fluorisis with 10% povidone iodine, and this was followed by ICD removal. Then we referred the patient to gastrosurgery and gastroenterology. They then later on planned for definitive surgery. This black pleural effusion till 2016, less than 10 cases were reported. A recent study of 2023 till 2023, around 30 cases are reported worldwide. And this is not currently well demonstrated in literature, being a very rare case. And then two most common causes of black pleural effusion are pancreaticopleural fistula and metastatic melanoma. Others include malignancy, adenocarcinoma, maybe lung, and also other adenocarcinomas, and fungal infections like Aspergillus niger, Rhizopus oryzae. And pancreaticopleural fistulas allows pancreatic fluid, which can be black due to the presence of blood and breakdown product, to leak into the pleural space. So this was it. Thank you so much.
Thank you, Vidisha, for presenting this case. So we have all our panelists here, so we know what is the case actually. So I wanted to know what could be maybe Munawar sir, what are the clinical signs and symptoms which we should suspect or raise the suspicion of pleuroparenchymal or pancreatopleural fistula? Do we have some clinical symptomatology which we should suggest?
Again, thank you, Richa and Dr. Vidisha Devi. Another fascinating case. Just like the previous case, I think this is well worthy of publication, and you should publish as soon as possible. There's not much written up on this particular topic. I think as far as clinical features are concerned, it's a bit tricky because unless you have abdominal symptoms to suggest some kind of a pancreatic pathology, it's difficult to suspect. Of course, this is on the right side, and we get pancreatic-related pleural effusions more on the left side because often it's the tail of the pancreas which is affected by pancreatic pathologies. Besides that, it's the pleural fluid which gives us a clue as to whether it could be pancreatic origin or not. I think, again, not a criticism, but in my own practice, if I had seen this patient, I would have proceeded to thoracoscopy much earlier. The reason I say this is with this, you mentioned at the second time when you went into thoracoscopy, there was a degree of adhesion, septation, etc. And it happens very quickly. You'll be amazed how quickly septations and adhesions occur. The moment you see a significant pleural effusion, which is undiagnosed and the etiology is unclear, unilateral, it's best to proceed to thoracoscopy very early in the process. I'll stop there and let others speak, Risha. Thank you.
Thank you so much, sir. And also, do we see this is in a very abnormal color of the fluid which we saw, Vidisha. I'm asking from the learning point of view, should we have suspected that this is certainly not normal looking, not looking like an empyema, not looking like an old hemothorax kind of a thing, which can turn brownish and all? Should we have suspected earlier itself and send those amylase and lipase levels earlier itself, or no?
Your question is to Dr. Vidisha Devi, is it, or to me?
No, sir, to you.
To me? Oh, yeah, definitely, 100%. I think any case which looks unusual, because besides the usual tests, we would have in the BTS guidelines very clearly given a list of things which you can analyze. And 100%, right in the beginning, we try to send for everything, including triglycerides and, if possible, chylomicrons, where the color is more light. And when it's darker and altered, looks like altered blood. This is an extraordinary case.
Yeah.
And congratulations for bringing it here and presenting. It's a great learning experience for all of us, including myself. And I think the more you do, the better early on. I would not hesitate in setting. I know the cost goes up in the private sector, but it's definitely going to save money in the long run for this sort of scenario. Yes, we should have.
So the thing is that when we got in the like smear, it was suggestive of hyphae. So immediately the thing that first came to in our mind, it might have been a
Absolutely.
fungal infection. So that's why maybe we didn't think of it in that way. And the patient, we
Sure.
kept on asking him. He was also not giving any abdominal symptom. But then I also read in the lights that most of these patients of chronic, pancreatitis with cirrhosis, they might not have, most of the time they do not have abdominal symptoms because of the fistulous connection, that thing that the pseudosis, it gets decompressed because it is continuously draining into the pleural sac. So might be that is the case, that he was not having much of a like insignificant kind of a abdominal symptom. So maybe that's the reason why we missed it in the first go. And when he came back again, then we when we probed back and we took his history back again, then we sent it. But yes, ma'am, we should have thought of it before, and we should have sent amylase. And because this was so rare, we have never seen such a case before.
True.
So
Yeah.
All of us are learning, Vidisha, so it's a rare case. And as we said, that is what we are just trying to learn. So something very unusual should we just send off earlier. The other question for all the panelists would be from my side, would be, she said that the hyphae were seen, but culture were negative. Is it very classical of having fungal related pleural effusion?
I would like to say this since I'm bubbling to say something. One, see hyphae in the pleural fluid, I would have gone back and done a CT again to see if there was some parenchymal lesion. Um, if I would have hyphae in the pleural fluid for a person who was otherwise absolutely non-diabetic, non-smoker, non-addict and everything, I would really take this with a pinch of salt and really like to see what is parenchymal lesions. And here, like Munawar sir said, with the hyphae, I would have definitely gone in and done a thoracoscopy in his case. Second thing, with the kind of fluid which you had, did you do a hematocrit, Pratisha? I mean, it was a completely amazing case, and the other thing is, how many times do we see a right pancreatico-pleural fistula? It's majorly on the left, then you start suspecting. And also, does this case become a learning point that if you have something on the right which is not really, it's an exudate not showing, then should you, as a rule, screen the abdomen to see if there's something in the abdomen which is giving rise to either the right or the left side effusion?
hematocrit, actually, we do not get reports here in the government setup. If we send pleural fluid ka hematocrit, they are not able to. I don't know why, but they are not able to get us the report of that. But we did suspect that it might have been a
old
So
hemorrhagic.
what was the other cells? You said that it was exudate and then stuff, but what was the cell cytology like? And what else
lymphocytic.
did it?
Lymphocytic.
It was lymphocytic and exudative kind of thing, and rest it was ADA was low. ADA was low.
Yeah, so no
Lymphocytic
RBC,
exudative low ADA.
no
And
RBCs, and
melanocytic.
they did not see any debris. No
No, they
RBCs and
didn't
no
mention
debris per
about.
se.
They didn't mention about RBCs.
Okay. The
Okay.
second, now let everyone
Yeah,
finish, and
please.
I have some questions on
Sure,
my
sure.
own. Yeah.
No, ma'am, please go ahead. You want to ask something?
So the other thing is that once we have found that the patient has a pancreatico-pleural fistula with an ICD in C2, the ERCP you said didn't show much. So
The
what should
MRCP
have been the
done.
thing?
We did MRCP.
The MRCP was done.
MRCP
Okay.
done. There we could diagnose that it was a cirrhosis with pancreaticopleural fistula.
So before we did the pleurodesis, the pleurodesis, did we think about giving octreotide or such analogs which reduce, you keep the patient NBM or put them on parenteral nutrition like we do with all pancreatitis patients? And octreotide, would that have been the route rather than going for a pleurodesis upfront? Is another question. Surprising 5 months from the first pleurodesis, there were barely any septic, surprisingly, from whatever you said had
5 months
tapped
back,
for
he's
that.
even 5 months back, ma'am, his pleural effusion was also not black colored. It was high colored.
Okay.
After this, when he came to us, that time, ma'am, it was black colored.
Black colored, yeah.
I think
Did he have any imaging for the 5 years back?
Oh, no, actually.
Months.
5 months back.
5 months back.
5 months back. So
I
do
don't
you
have it
do
with me right now.
do you do the ICD insertion of fluid tapping with image guidance or without image guidance?
Image guidance, sir. Ultrasound guided. Most of the times, ultrasound guided.
Okay. So I think there's a learning point in this. If you have undiagnosed pleural effusion, we should go ahead and screen abdomen and pelvis, maybe male or female. So we may be able to pick up a lot of things in that. And that's again mentioned in BTS guidelines also. As we underage effusion, you should go for a CT scan of abdomen as well as pelvis. So again, we
Agreed.
would have picked up some
That's
results.
interesting to understand and learn that if you are not able to find something in the chest, then maybe look at the abdomen. That may help you. So if you're at the undiagnosed pleural effusion, that's interesting. I
So
think,
just out of curiosity, sir, just can I ask a very small question to all
yeah,
the
please.
pulmonologists? That I mean, and when you have a case of pleural effusion which is not regular and standard, just like sir mentioned that we can add a CT abdomen. How often do you send pleural fluid, amylase, and lipase, or only if you suspect pancreatitis would you send pleural fluid, amylase, lipase,
Left
or is it
side,
not,
left side,
not
yes, I
routinely
do
done?
it regularly, but right, I wouldn't have suspected as much.
I
Uh,
think, yeah, please.
From our
Correct. I
side,
mean, of
no,
course,
we don't routinely send lipase or amylase until there is a history suggestive of, or there are abdominal symptoms and it's a left-sided effusion, but regularly no. But in this case, what I was saying was this was looking absolutely abnormal kind of a fluid. I've never seen the black effusion. I did had seen altered, hemorrhagic effusion, which have turned out to dark brownish and all, but this was looking totally different one.
So
yeah, I was
why
hoping
one
that
would do amylase lipase in a black effusion? There's nothing like doesn't fit into it. So I mean to say it was a very unusual case, and probably we would have tried and done everything possible to find out a diagnosis. But then specifically amylase lipase in this situation, I don't know whether we could have thought about it.
So, but when stuck against the wall, we don't know anything. I think so. All the tests, like Dr. Munawar mentioned, we should send these tests. And
Probably
I
yes.
think we all do send also. We all do send these tests. And Dr. Vidisha, did you find out what was that herbal medicine which caused all this
He was
pancreatitis?
he was
Pancreatitis would have been.
actually so he was actually hiding it from all of his, even his like spouse also didn't knew about that, but he was taking it for a long time. So when we kept on probing, then he said, are you taking any kind of other medications, because he was non-alcoholic, first thing. So first thing that we have to keep in mind, like for pancreatitis, that person is like 90% of them, they are like alcoholic. So he had no history of alcohol, so we were also confused. We kept on asking. That's when he told us, and he couldn't specify sir what he was taking.
That will help you in your publication subsequently. At this time, I
Yes,
would have.
Can I ask just one question, sir, if you don't?
Yes.
When we did the CT thorax in the first place, I mean, it was such a big pseudocyst that CT thorax generally has abdominal cuts up to the pancreas
Yeah.
sometimes. They should have picked that up there. I'm surprised that such a big cyst could have been missed in the CT thorax. I mean, the thorax is good enough. They go up till the adrenals, at least as a standard.
Yeah.
Yes, agreed. I think that they should have reviewed that old CT scan. Maybe they would have picked it up there. So I think we move on to the next question. This question is Dr. Manu. What is the preferred imaging modality to diagnose a case of pancreatopleural fistula? CT, MRCP, or ERCP? How you would go for that? Dr. Manu, please.
Sir, of course, as we have seen earlier, that a CT scan will be able to pick up initially. We will have a abdomen cuts and will be able to find out there is a communication. But I think MRCP is the diagnostic modality of choice to confirm a uh, link or a connection between the pancreas and a pleura. So MRCP should be the modality of choice.
Okay, so MRCP would have been because a lot of times CT may miss communication. You may not be able to
Yes,
see
sir.
on the CT.
Yes, for communication you require MRCP, sir. But of
Mhm.
course, you may find some lesions on the abdomen. MRCP will be able to pick up the communications.
Okay, I think that's the test which we all will do. Anything else any of the panelists would like to suggest? I think then we move on to the next question. Again, this is a question which probably we have already discussed, but is there any role of pleurodesis in a patient with recurrent pleural effusion due to a pancreatopleural fistula? Is there any role or no, we should not? Dr. Munawar, sir, what's your opinion on this?
So if there is an underlying cause for pleural effusion, we always try to approach and treat the root cause of the pleural effusion so that there's a more definitive approach to management. If despite treatment of the underlying cause, or if it's not possible to treat the underlying cause, whether it's pancreatic pleural fistula or anything else, then and only then we would consider pleurodesis in a benign pleural effusion. So that's the principle with which we have to operate. So here, for instance, you were, quite rightly pursuing the possibility of getting definitive treatment for the underlying cause.
I think when we talk about, I was discussing with Bidisha when she just sent this case, and I asked because normally when we look at uh, these cases, the diagnostic as well as therapeutic management comes in terms of ERCP. So why, and usually most of the time after stenting, the fistula heals and it treats the case. As Sir said, pleurodesis may be required for refractory cases, maybe as the last option, but not as the first option. So, Bitisha, would you like to add why pleurodesis was done for this patient at the first instance while he was the surgeons, the gastrosurgeons, and the gastro people were still waiting to plan a definitive management, right?
So first thing, ma'am, it was like first time like 5 months back he had massive effusion. Then again 5 months after that he had massive effusion. Then we did thoracoscopy. Then again the fluid accumulated. Patient was symptomatic. So and like gastro because we have a lot of load in the government setup. So they were like this plan was about 1 month. So they were delaying it for 1.5 months, 2 months. So we thought maybe this would help him only for the patient's symptomatic relief. Only we did this, and that was the only reason why we did this.
Yes, so I think that's again a very much learning point that sometimes we don't go by the guidelines, what is mentioned, because of the local unavailability of so many, the lab diagnostic as well as the expertise for doing the procedures or things like that. And to help the patient, we have to go out of the guideline. But if I have to say, probably ERCP does the most of the it is therapeutic and it does help. But to Dr. Kamran, do you think there is endoscopic versus surgical? I mean, no, you are a CTBS surgeon. This would be dealt by mostly the hepatobiliary people. But what do you feel, endoscopic versus open surgical option?
I think, ma'am, whatever I remember from our general surgery days of pancreatitis and pancreatic fistulas, a lot of work was from the surgeons was taken over by the gastroenterologists.
Right.
And this is a surgeon's nightmare in all specialties.
So, as I remember, masterly inactivity was the word for pancreatitis when it came to surgery.
No,
Be it
definitely, ma'am.
necrosectomy. Yeah.
Absolutely.
So
For
it
pancreatitis,
was
yes. But for pancreatic fistula, we
necrosectomy
used to
with
do a lot of
fistulas
internal
and this.
drainages and a lot
Yes.
of.
So now they do the
But now it's all
cystogastrostomies, I think.
endoscopic.
Yeah, cystogastrostomy, whatever my colleague does most of the time.
Correct.
Is a
So most of this
cystogastrostomy.
is now dealt endoscopically. So I think it's one more specialty, one more area where surgeons are now taking a back seat.
Yeah, true. So I think endoscopy does. So, um, uh, anybody has any comments to put on before we move on to the third and last case? Or, I mean, it is certainly, Vidisha, it's a wonderful case, and within the limited uh, uh, availability of the diagnostic as well as surgeons and all those things, you have managed it pretty well. And as Munawwir has said, it should be published. It should go for publication. It's a good learning case. And Dr. Kamran has something to say.
Just a small thing. When I first saw the image of the black pleural fluid, my thing was that, oh, it's a melanoma.
Yes.
Because in surgery we were taught anything black in the body is melanoma.
Yeah, so you're right. I mean, in all these years of this thing, we have only one black color effusion, and we went ahead with the thoracoscopy, and we could see those deposits, the typical deposit, and it came out to be melanoma, but certainly not this pancreatic pleural fistula.
I would also be interested, Vidisha, now that we've closed the right side, what happens to the left side eventually? Maybe you can wait for another month and publish that too.
Hopefully, ma'am, if the patient comes back to us. But then, ma'am, one thing, it was for a first year, it was a complete learning experience. And one thing that I have learned, that history, we should always take the history properly. And the basis of everything is the history. Had the patient told me that he was taking some sort of like herbal medications and abdominal symptoms, and maybe I would have thought about the CT abdomen back then. And also, being a respiratory person from respiratory medicine, most of the time we ignore the other organs, systems and all. So this shouldn't be. So we should treat the patient as a whole, and also like keep in mind that we have to keep in mind the other systems as well. So it was a big lesson for me, and since then I have always like concentrated on the history again and again. Like,
Yeah, it's a good learning, Vidisha.
Yeah, it was a great learning, and thank you, Dr. Bidisha.
Sir has to say something. Munawar sir has to
Yeah,
say.
please.
No, just a general comment. I mean, the comments that we're making on the cases, this is to yourself, Dr. Srinivas Gopinath, and the next presenter, is when you just constructive comments, please don't take anything personally, because there's retrospectoscope, as we call it, is a beautiful thing. We can tell a lot of things about we should have done this way or that way, but when you're on the heart of the moment of the case, you've taken the right decisions for that particular patient. They're just different routes to the destination. That's what I'm trying to say.
Yes, sir.
Thank you.
Thank you. I think with this case, we now move on to the next case. And this is the third and the last case, which will be presented by Dr. Divya. She is from the Department of Pulmonary Medicine, Osmania Medical College, and she's a JR2 in the Department of Respiratory Medicine there. Dr. Divya, please.
Thank you,
Please
sir.
present your case.
Good evening to everyone present here. I'm Dr. Divya, JR2 from Department of Pulmonary Medicine, Osmania Medical College, Hyderabad. Going into the case, I'll be presenting a case of bilateral pleural effusion. In the background, approximately 95% of bilateral pleural effusions are often attributed to a single etiology. However, in rare instances, around 0.9% of bilateral effusions may arise from two distinct etiologies. Going to the case details, we report a 35-year-old female diagnosed with ovarian carcinoma, stage 4B, status post neoadjuvant chemotherapy, cytoreductive surgery, and adjuvant chemotherapy. She presented to our department with complaints of chest pain and shortness of breath since 3 days. And on examination, her saturation was around 92 with room air, and she was tachypnic and tachycardia was present. And respiratory system on auscultation, there was decreased breath sound intensity in bilateral mammary area and interscapular area, and there was absent breath sounds in bilateral infrascapular and infraaxillary area. A chest X-ray was done, which revealed bilateral mid-zone, lower zone homogeneous opacities with blunting of costophrenic angles and silhouetting of the diaphragms, which is suggestive of bilateral pleural effusion. A PET-CT was also done priorly, which was suggestive of bilateral pleural effusion, left more than right. And a routine investigations turned out to be within normal limits. Sputum for culture sensitivity showed no growth, and sputum CBNAT for MTB was also not negative. We then proceeded with thoracentesis. Initially, left side pleural effusion was aspirated, which turned out to be hemorrhagic, and it is a low ADA exudative effusion, and the pleural fluid cytology was suspicious of malignancy, and the pleural fluid cell block was consistent with malignant effusion, and pleural fluid Gram-Stein culture sensitivity showed no growth, and pleural fluid CBNAT for MTB is negative. Since the cell block was suggestive of malignancy, we proceeded with a pleural biopsy, which was consistent with metastatic ovarian carcinoma, and the immunohistochemistry showed PAX8 and WT1 positivity, and TTF1 napsin negative. And then we proceeded for a right side thoracentesis also. The pleural fluid appearance was straw colored. It was a high ADA exudative effusion, and the cytology was a lymphocytic effusion, and the cell block was negative for malignancy, and pleural fluid Gram-Stein and culture sensitivity showed no growth, and pleural fluid CBNAT for MTB was deducted, and it was rifampicin sensitive. And later on, we sent the pleural fluid for MTB culture also, which yielded growth of Mycobacterium tuberculosis. The patient was then started on antituberculous therapy for the right-sided tuberculous effusion, and she was further referred to the oncology department for further palliative care. So this the first X-ray shows the X-ray at the time of presentation, and the second X-ray, which is suggestive of bilateral pleural effusion, and the second X-ray was taken 3 months later when she came to us for follow-up, which shows resolution on the right side, and metastatic effusion is still present on the left side. And this is the immunohistochemistry report of the tissue biopsy. So going into discussion, I reported a case of Conterani syndrome, which is a condition in which the occurrence of bilateral pleural effusion is attributed to different causes for each side. The most common combination in this syndrome is heart failure with a transudate on one side and a parapneumonic effusion or an empyema on the other side. The second most combination is a chylothorax on the one side and a malignant pleural effusion on the other side. In this case, we report a rare coexistence of a malignant effusion on one side and a tubercular effusion on the contralateral side. So reviewing the literature, there are no specific criteria mentioning when to perform bilateral thoracentesis, but some studies suggest that bilateral thoracentesis can be considered in certain conditions like elderly age, immunocompromised, and with presenting with unusual clinical features, asymmetrical effusion sizes, with bilateral effusion having different CT attenuation values, or unilateral resolution of effusion if it is present. So Conterani syndrome, though it is rare, it is likely underdiagnosed due to assumptions of a single etiology in bilateral effusions. So therefore, it is important to consider Conterani syndrome in a case of bilateral effusion as a cause, as further management will differ in such cases. This case highlights how bilateral thoracentesis can be pivotal in diagnosis and management. As Hickham's dictum says, rather than assuming a single etiology, it is important to consider different etiologies in some cases of bilateral effusions. Thank you, sir.
Thank you, Dr. Divya. Now we move on to our panel discussion. My first question is to Dr. Munawar. Sir, what are the key clinical red flags or patient history elements, or what are the key reason why when one should prompt or one should consider doing bilateral thoracentesis rather than unilateral? Because most of the time when you have a bilateral effusion, we tap on one side, we don't tap both the sides together. So which are the situations when you would suggest to do a thoracentesis on both the sides?
Yeah, again, a fantastic case, Dr. Divya, and very nicely presented too. I think so much to learn in today's MDT from me as well. It's very uncommon for us to do bilateral thoracentesis. We teach people not to intervene on both sides in the pleura for fear of getting a worse outcome and pneumothorax and bilateral pneumothorax, bilateral complications, etc. So it'd be extraordinary. But if something does not add up, and if you, for instance, suspect a cardiac failure as the cause of the bilateral effusion, but certain things don't add up, as in, for instance, if you start off with a large left-sided pleural effusion and a small right-sided pleural effusion, and you aspirate the left side first, and you find that it's clearly an exudative effusion, something's not right. And there you start investigating as though you're dealing with some abnormal scenario, atypical scenario, and where you would normally do, investigate only later, assume that it's cardiac failure and treat the effusion. Once you see an exudate, you start investigating almost like a malignant effusion or an exudative effusion, and you start doing contrast-enhanced CT with a venous phase, etc. Then, if you find some atypical features on one side, and something on radiologically that there is some abnormality on the right side, only then I can think of aspirating the other side as well. So like you have done correctly here, you have aspirated one side, you found something unusual, and then gone on. That's the only thing I can think of. Otherwise, I can't think of many instances, although we run a specialized pleural service, that we go ahead and aspirate both sides. I don't know about the rest of the panelists.
Very uncommon to do a bilateral thoracentesis, only very, very selective. What's your opinion, Dr. Richa? You are mute, I think.
No, I agree with sir, because normally you do not end up doing bilateral sentences. I mean, otherwise, until and unless you find there is no reason there is no cardiac cause, no renal cause, no liver cause for bilateral effusion, and then you have to aspirate. Usually, bilateral effusion with an underlying cardiac or those cause, you should not be aspirating, is what the dictum says when you're suspecting transudative. So those causes are not there, then you do aspirate, and if it is exudative. So yeah, it's very rare, and I'm also just wondering what should be the, as you asked, no, red flag. Probably in this patient, Divya, would you want to highlight why did you do, I'm sorry if I missed on, why you went ahead and do diagnostic tap on both the sides?
Ma'am, we did left side only, but since patient was already, he's a known carcinoma patient. She's a known carcinoma patient, and there was no history of any transudative, there was no history suggestive of any transudative effusion also. And this was also suggestive of malignancy. We just want to know whether that side was also malignancy, and we were also thinking about contrary also, ma'am. So we tried to. She was also immunocompromised, and so that also we considered. She's an 35-year-old, and she was already stage 4B carcinoma with ascites, bone mets, and everything. So we just wanted to know.
So we have seen only one patient with Contarini syndrome, and in that case, why did we do was because on one side, when the diagnostic tap was done, it was exudative, and expert was positive on pleural fluid, so TB. But then had a CT scan which was showing a mass kind of a thing, not a mass but a big nodular kind of a thing, which was not fitting on the left side. It was not fitting, and there was an effusion as well, and that's what we thought that will. Though this was expert positive on the right side, we went ahead and did a medical thoracoscopy on the left side after diagnostic tap, and it turns out to be malignant. So that was the only one case because this radiology was abnormal. We went ahead and do, but other panelists may also put.
Dr. Manu, any opinion from your side?
Sir, again, interesting case. This was also an interesting case. Of course, I also wouldn't have gone ahead with the pleural tap on the right side. And as Dr. Richard told, it's also most of the time it's like a patient who's on tuberculosis. You have diagnosed a case of tuberculosis. Patient is not responding. The CT picture is not consistent on the other side with tuberculosis. You may find some nodules. Then you go ahead and do a tap or the thoracoscopy, and then you find malignancy. So we have seen patients of tuberculosis with malignancy, but here in a proven case of malignancy, and on the right side, incidentally, they just did a pleural tap and found out to be TB is actually. I wouldn't have done it. I would have just gone on the one side and found that okay, it's a malignancy. I would have gone the other side would also be malignant pleural effusion only. So again, it's interesting, and I think so. It highlights that we may do some cases wherein with the bilateral pleural effusion, and we may see that if do we very commonly see this type of Contarini syndromes in our practice.
No.
Food for thought for subsequently.
We hardly see Contarini syndrome in our practice. Very, very uncommon.
Very uncommon, sir. Very uncommon.
So I think interesting case. Now we move on to our next question. This question is again to Dr. Manu. How can advanced imaging techniques like contrast enhanced CT or ultrasound help us in identifying subtle differences between the two effusions that may not be apparent on a standard chest X-ray? Can that help? Imaging may help to decide
Yes,
whether.
sir. Now, in case of if you see for exudative effusions are supposed to be more proteinaceous. They're supposed to be thickened effusions. And if you have got a contrast, so we'll see the split pleural sign and those things. We may see additions, bands, which can be seen more so in the venous phase of pleural. Thickening can be seen in case of exudative pleural effusion. And for transudative, of course, the pleura will be clear. We will not find anything in these cases. So that I think so can be helpful in cases of a we can say a contrast enhanced CT for exudative pleural effusion vis-a-vis a transudative pleural effusion.
I think the presence of diaphragmatic nodules or nodules in the pleura, particularly pleural thickening, and whatever you have is that points towards malignancy, which is even seen on the ultrasound, need not be a CT per se. I think that is one more important point in this. If someone wants to add, I wanted to ask Dr. Munawar specifically about the venous phase for the pleura. I have actually missed out on getting this done, or probably the radiologist sees this, and I've never seen per se for the pleura on this. So can you just put up some points for the venous phase of the for the pleura? So we do the venous phase for the other malignancies and masses. For the pleura, I somehow have never followed up with the radiologist. Neither have we discussed about this concept. So how does it help, and where should we follow up?
Yeah, there are studies to show that in the venous phase, you pick up more abnormalities in the pleura that you would have otherwise missed if it's not in the venous phase. So when there is a suspicion of mesothelioma or any other pleural abnormalities, pleural pathologies, with our radiologists, we usually plan a venous phase. When you write the protocol, when they protocolize, they suggest the venous phase. We've written up about this many years ago in a couple of articles. Showing this, yeah.
I think that's important that any patient with pleural disease coming for a CT scan, always we consider doing a venous phase. That's what I think. Dr. Richa, you get
The
it done.
contrast, but I have never really specified, or we've never dwelled on this fact of the venous phase. Possibly, if I go by and talk to them, maybe I'll get a little more insight.
Most of our pleural pathologies we do with ultrasonography first.
But whenever you need a CT, then probably you go for the venous phase. I would say we'll go for the venous phase contrast CT.
There's just one thing to remember when you ask for the venous phase, just to remember, ask yourself what you're trying to achieve with doing the CT scan. Because if you're looking for other pathologies at the same time, the venous phase may not suffice. So that's why it's important to discuss with your pulmonary radiologist and discuss what is the likely differential diagnosis you're approaching, what questions are you trying to get answered with the venous phase. Like Richard just mentioned, actually, it's a very important point because with us using more and more pleural ultrasound, most of us, it's not become as important because the pleural ultrasound sometimes give more information than your CT image, because you can do so much with the pleural ultrasound. It's dynamic. You can repeat it. You can see in different angles. You can do so much more.
Sir, if I may add, I think so. It's a venous phase. We have more contrast deposited in the pleura. That enhances small lesions also, which we may not be able to pick up on ultrasound or on a routine CT scan. So that's why we highlight for a venous phase of a this thing CT scan. So for those small nodules, those small lesions can be picked up on a venous phase. And if we are suspecting malignancy, more so if it's suspecting malignancy, in this case.
Would rather go for medical thoracoscopy, Manu.
I mean, it's a normal CT, just has to wait for a contrast to be there for some more time.
Another question which if I may ask all the panelists, since Dr. Divya already had a pleural fluid cytology showing malignancy, how much is the relevance of doing a pleural biopsy in this case for the further IHC and these studies?
Probably not. I would not do it because we already have a confirmed case. So I would have not done a biopsy. What is your take, Dr. Isha? You are mute.
Sir, I think everything depends on how your radiation oncologist or medical oncologist is wanting to do. So if you have a good cell block and all the markers can be done, then there is no need for pleural biopsy. But if that is not the case, it is, say, then probably you might have to go ahead. So for us, it is like that. If the cytology is suggesting and the block is enough to give you all the markers, to run through all the markers, then no need for the biopsy.
If it is already a spread metastatic disease all over, would you still do?
Sometimes, sir, they need to look for mutations and they need to do the further markers. But sometimes the cell block is sufficient enough, or is it not? And we need to go in and get a pleural biopsy is my question. The second question I would like to ask is, what is the role of something akin to a blood NGS? Is there some role of pleural fluid NGS in certain tumors? Munawar, sir.
Yeah, so, there are studies on this showing that pleural fluid biomarkers for malignancy, we're not there yet. There is some studies. It's nicely summarized in a table. Actually, it's in the BTS guidelines from last 2023. But the very relevant question that you've asked is about whether you need to do biopsy or not. 2-3 years ago, I would have got away without doing a biopsy. But only recently, I had 2 patients where the gynae MDT came back to me and said, can you do a thoracoscopy and biopsy because we are doing more next generation sequencing and biomarkers, and this pleural fluid bit is not sufficient. So we have to, before proceeding to biopsy, we have to ask the pathologist whether we can do everything in the armamentarium to get all the possible information. And we have to ask the gynae oncology MDT, whether they are happy with the material that is there to give them all the necessary information. Even metastatic disease, they do a lot more these days. So they ask for a biopsy sometimes.
Yeah, and also the way oncology treatment has advanced. So, they are medical oncologists. They, even if the patient we know is an advanced malignancy, patient is on treatment, first line of treatment has failed, then they would ask us, the pleural effusion suppose is there, they will say go ahead and do the thoracoscopy. We need to go for NGS and further markers to define what should be the course of treatment. So I think people are becoming more aggressive, and that is why depending on
In some cases, yes, we may have to do.
Is looking at. If I would ask Vrishali, or anyone want to answer, what are the common combination in Contarini syndromes in terms of etiologies? If we have seen, for me, I have seen only TB and malignancy. One of the
I think the other combination which I might think about is that if a patient who has something like a CTD, a connective tissue disease, and even in uremic pleuritis, you might have a combination of, again, tuberculosis with pleurite, uremia, or a CTD on one side and tuberculosis. Though I haven't seen any Contarini till date, and where we have gone and tapped the other side because the patient is breathless, more than rather than looking for a second kind of a disease process.
The original combination, Francesco Contarini itself, was CCF with paraneumonic effusion. And we see more and more malignancy, and in the Indian context, you have to bear in mind TB. Indian context, but actually it's in many other countries, including I'm seeing TB in greater numbers. So it's not just the Indian context, anywhere else. You have to bear in mind the possibility of TB.
I think we move on to the next question. This question is to Dr. Munawar. In the absence of large-scale clinical trials, what are the best way to build a robust evidence base for the diagnosis and management of Contarini syndrome? How should we develop a guideline or the more robust evidence to manage these cases? What should be way forward for us?
Great question, Sushil. Thank you for asking. I was thinking about this the other day. You have done exceedingly well to set up a pleural MDT and a pleural network, much needed in a vast country with the abundance of clinical material like India. If only it would be possible to agree on data points and have a database where you can pool in information, these sort of rare conditions. The ERS, for instance, we have a collaborative to look at, say, eosinophilic pleuritis, etc. Those are drug-induced pleuritis. There's a study that's gone on to pool in data. I mean, in India, you could, with all the brilliant work that is being done by all of you across the country, you could pool in and collect these cases. And the case that you have just presented, Dr. Divya Ravi, like this, you can take the lead and potentially set up for Contarini. Get your data in and analyze the data you decide on the data points, what data you want to collect, and then you bring together the pleural MDT. It's so much easier with the kind of social media, the WhatsApp university that you have now, that you can bring everybody together and make it productive by collecting the data. Suppose you get 20 cases, that'll be the largest series in the world. And you can look at, analyze the data. I'm very happy to help in any way, but there's enough expertise even in this panel to do that. So I would strongly encourage, that's the way, not just for Contarini syndrome, but other rare conditions. A unique scenario, because Contarini syndrome, there'll be a higher incidence in India because tuberculosis is triggered, as we know, reactivated by other conditions. So we forget that very often. We treat the tuberculosis, forget that something else has unmasked the tuberculosis, isn't it? We have published previously dual pathology, TB and lymphoma, ages ago. Like this, I'm sure all of you have come across TB with sarcoidosis, TB with lymphoma, TB with various malignancies. So great opportunity, I think.
Now that you say, sir, we had lymphoma and TB in the same site in the same patient. I mean, I didn't have a Contarini, but yeah, remember this, yes.
Yeah, you might see that as well when you collect your cases together.
Same side.
Pool your cases across.
I have seen a patient who had an empyema on one side, bacterial empyema, other side it was tuberculosis. So that I have seen. So a case of malignancy with TB, that also we have seen. I think this is the common scenario we see in India. But then again, a very rare situation. Maybe we can collect data from across country and have 20 cases. I think that we can get it.
Well, you probably get 50 plus if you start collecting.
I think we wind up today's MDT, Dr. Richa.
Yes,
Take the
so
lead.
we really had very unique cases and good cases. And, as Sir Munawar sir rightly said, nobody is right or wrong because they are rare cases and not too much is mentioned as well. So, whatever we felt right at that point of time, in that situation, we have done. And I must congratulate all the three presenters. You did very well and you managed very well, and you presented and enlightened us as well as the audience who have joined with us. We would like to thank all the three presenters, Divya, Vidisha, and Dr. Gopinath, along with our esteemed panelists, Munawar sir, Rushali, Dr. Kamran, and Dr. Manu, along with Sushil sir and myself. That all of us are together, and we spent 1.5 hours discussing about these cases. And sir, Munawar sir, your point is well taken. I think there's a dire need of people to come together and put up something concrete which would be useful for entire world as well.
Dr. Munawar, you want to give some last comments for us?
No, congratulations to all of you to set up this MDT. It's such a pleasure to be here. It's an honor, I have to say.
It's an honor for us. For you have been there with us, so it's an honor.
I must admit, I've learned a lot today with this MDT, and I can see from the delegates that it's international, not just national attendance, which is a tremendous achievement. And to all the presenters and the panelists, thank you so much. Lovely to hope to see you in person in the near future. Okay.
Thank you so much, everyone. Good night.
Any comment from the panelists, other panelists, please?
Sorry.
I think
so I was hoping you would ask me what would you do in a bilateral empyema, Kamran? So I'm glad you didn't ask that question.
What will you do with bilateral empymas now that you triggered it up?
It's a surgeon's, any bilateral disease, whether it's bilateral hydatid, bilateral bronchiectasis, or bilateral empyema, is a surgeon's nightmare. We would not like to deal with them. It's always a difficult situation. I mean, the just general practice is to deal with the worst side first, if possible, and not try to do two surgeries at the same time. It leads to a lot of pain. Patients don't breathe well, stay on the ventilator longer. And if you have not done, I mean, even if you've done a great job with decortication, you expect some air leak in the first few days, and having air leak on both sides is not a great thing. So obviously, not a great thing to operate for.
You just missed the youngest panelist. She appeared and disappeared, yeah?
Anything you want to say, Dr. Vishali? Oh.
I think we made that point, if we have a right or a left pleural effusion, which is otherwise not, I mean, we've done a thorax, so screening for the abdomen is quite important, or thinking about the abdomen is quite important in the atypical cases, yes. Right. And, if you're getting some bacteria in the pleural fluid, culture is negative, or you see the fungus and it's negative, where you're not expecting it, I think sometimes it is your contamination, which everyone has to be very well remembering, particularly we're getting gram-positive organisms, and we really did not suspect an empyema or a fungal empyema. I think lovely cases. I mean, really lovely cases.
Dr. Manu has already left. Huh?
Manu is there?
I think now we end up today's MDT. Thanks to all the panelists. Thanks all the case presenters. And special thanks to Dr. Richa Gupta for helping us to make this panel discussion on MDTs so successful. We hope that we'll continue doing this every alternate month. And thank you, Dr. Munawar sir, for being here with us. And I think thanks to all the audience, thanks to our audiovisual team, thanks to Cipla who has helped us to organize this MDT. I think we take a leave from here, and we hope to see all of you soon. Thank you.
Thank you, everyone.
Thank you.
Thank you.
So, like Munawar sir said, we should not forget that, now since Contarini has started, we should put up on the group everyone to share their Contarinis and maybe similar like a black effusion and what has it eventually been. I think, that really makes sense in putting up all our cases together.
Yes.
Lovely suggestion, sir.
Absolutely.